extremely lazy, and it seems to take additional steps to activate them, as opposed to other diseases like cervical and endometrial cancer.
Yeah. All right. Thanks very much. I know that it's late for you, Dr. Konechny. We have a slight shift in the program given our time constraints. Where next talk, we're going to move on to our genetics discussion so that we can move up our panel. I know that many want to hear about circulating tumor DNA, and we will play that video in just a few minutes. But we're going to change the schedule of the agenda a little bit, and we're going to talk about cancer genetics next. Then we'll do our patient experience panel, and then we'll come back to circulating tumor DNA. So I have the pleasure of introducing next my friend, I have my friend Julie Mack, who is our genetic counselor extraordinaire who works with us in our hereditary cancer program, and also one of our senior genetic counselors in our cancer risk and prevention program. Teaming up with Julie is Monique Tiffany, who is joining us from Myriad Genetics, and we wanted to have them give you all some insights into the latest in cancer genetics that's applicable from the patient level. So Julie and Monique, take it away. Thank you.
Thanks so much, Dr. Chen. And I think Monique, thank you so much. Monique's going to be our driver of the slides here. So thank you so much for the kind introduction. As Dr. Chen said, the title of our section of this talk is Hereditary Factors and Biomarker Testing. I just want to acknowledge I really enjoyed listening to Dr. Brooks. I'm looking forward to hearing Dr. Chapman's talk. There's immunotherapy, there's circulating tumor DNA. And I think what I really want to acknowledge is there are so many different types of tests that we do now, including many tests that involve genes on some level. And so you, as a patient, it can get really overwhelming. Like, which genetic test did I have? Didn't I already have that test? So I'm actually going to start off, and I don't know if other people are seeing the same thing, but I think, Monique, I'm seeing like the PowerPoint, but not the presenter, like the presentation. But I just wanted to kind of give you an outline of what we're going to be talking about, which is first to just talk about the two very
if I can interrupt you,
categories of
Julie, I'm so sorry, but it's not letting me switch the presentation mode. And I'm wondering if
I
we
can
get
certainly
Kevin to share it
Oh
for
yeah.
us. It's not letting me utilize my screen the right way. Let me try taking it off the second screen and see.
Yeah, thank you. Sorry about that, Kevin, if you have it, or if there's like some sort of privileges that you can give to Monique. I can kind of keep us a little bit on track by just saying my first slide is really just telling you what I'm going to tell you, which is trying to distinguish between different types of genetic tests and the two really broad categories that I want to, oh, here we go.
You're working?
Yeah, it is, at least for me. Two really broad categories I want to talk about are germline tests, which are tests to look for inherited genetic things that are inherited in our genes, and somatic tests that are trying to learn about the genetics of cancer cells. And a lot of things that you're going to be hearing later about circulating tumor DNA that you just heard from Dr. Brooks in terms of immunotherapy depend on looking at the genetics of a tumor and what's going on in those cancer cells. My area of hereditary cancer is more what's going on in your normal cells. What are the genes that you've been inherited from your parents? So as I said, I want to give an overview of that. Then I'll talk about my area of expertise, and then pass it on to Monique. So here's the overview. I really love this slide, which has been adapted from many places. I got this particular, you can see it was adapted from the NIH, but I got this particular version from an organization called FORCE, which is a fantastic support organization for individuals with inherited risk factors for cancer. And on the left of this, you can see how most cancers develop. So sporadic cancers mean cancers that develop just in that one person. And this is how most cancers happen. People start off on the left with those gray, normal, healthy cells that don't have any genetic problems. But as we go through life, just through the natural process of aging or things that we get exposed to, or honestly, unfortunately, some bad luck, we can get damage to our cells that may cause a genetic mutation. Usually, one or two of those our body can tolerate, our body can work with. But if enough of them accumulate, and you can see in this picture that bottom right corner, the orange cell, the cancer cell, has many genetic mutations. And so that is what makes it unhealthy and turn into a cancer cell. And on the right side of this screen, you'll see the hereditary cancers. And this is the area, again, that I'll be talking to you more about. And here you can see that in people with an inherited risk factor, their normal healthy cells, when they start off life, that very first, in this case, the teal column, already has a genetic mutation. They actually inherited a genetic mutation from one of their parents. Again, that's not enough to cause cancer on its own, but the same things can happen: age, environment, bad luck, that can lead to a cancer developing. And I want to stay on this picture for a moment to, as I said, make kind of a big distinction between all the different tests you're hearing about for hereditary cancer, where we're trying to understand what is being passed through a family. Then in my world, we always look at normal cells, which would be the cells on the left. And most people that we do genetic testing for, when we look at their normal cells, nothing's going to be there because those cells don't have any genetic problems related to cancer. But what we're trying to do is find the families that have, on the right side, their normal cells may already have a genetic mutation. And if we can do that, we may be catching people before they get cancer and be able to help monitor them more closely or prevent something. And I'm going to stay here for one more moment. If you can go to the next slide, Monique. Thank you so much. So I started saying this already, that for the hereditary testing, or what is sometimes called germline testing, those terms are not exactly the same, but usually kind of interchangeable. We're usually looking at healthy cells like blood or saliva. And the purpose of it is to understand what's the risk of cancer in this family and take that information to try to prevent cancers or catch them early. And this type of testing can be ordered by people like me, genetic counselors, but can also be ordered by doctors, nurse practitioners, other people as well. And I want to contrast that with tumor testing. And as I said, there's many different forms that this can take. So circulating tumor DNA is a form of tumor testing, but all of these essentially will be tests looking at those orange cells on the bottom right of the prior picture. All of those tests are looking at the cancer cells and trying to learn what is making them grow, what treatments are going to work best. And again, there's always some variation, but these are usually ordered by your oncologist. So that's just the stage I want to set to say there's many different types of tumor tests. We're hearing lots about them today. I'm going to shift to talking about germline or hereditary testing. And I don't expect in one morning that as a patient, you necessarily are going to understand the difference between all of these tests. But I think the important message to know is, like, if somebody uses the term genetic or DNA, that it may mean many different things with many different purposes. I think we can move on to, as I said, sort of my area of expertise here, which is hereditary cancer. And in some ways, we could say it's rare in that most people who get cancer, that is an isolated event that happened just to them. If we kind of think back to that earlier picture, their cells started off perfectly healthy, but over time, a part of their body developed cancer. That's how most cancers happen. What my area of focus is trying to find those families the pink slice of the pie here that have a hereditary cause to their cancer, the people that were born with that genetic mutation. And the reason that that's really important is because these people are at higher risk for getting cancers, and we want to take care of them in a specialized way. The numbers are going to vary depending on the type of cancers. Since we're talking about gynecologic cancer today, I want to mention ovarian cancer is one of the more strongly genetic types of cancer. It's about 20% of people who have ovarian cancers will have a genetic cause. It depends on the exact type of ovarian cancer, but that's not the purpose of this talk. For endometrial cancers, about 5% of those have a genetic cause. And there are other types of cancers that we are talking about today that are not never, but rarely genetic. So those are much less common. And again, not the purpose of today's talk, but since some of you may be saying, Julie, you talked about the yellow part of the pie and the pink part of the pie, and you didn't talk about the blue part. These are just the families that, I shouldn't say just, these are the families where we suspect something is going on, but we can't pinpoint exactly what it is. So, things rarely are all or nothing. We're still lots left to learn. There may be families that are at risk and we don't have the tools to identify them. And then, thank you. This is kind of calling back to that first slide, which obviously you can tell I love a lot, but the reason I'm bringing it back now is because it really helps me visualize what are the signs. Why does your doctor ask you about family history? Why, if you're seeing a genetic counselor, do I make you fill out this big family history questionnaire? Because we're looking for the patterns that might give us a clue. How do I find that pink slice of the pie of people who have genetic risk? If you look at the hereditary people with the right side of the picture there with hereditary cancer, you can see that because people are born with one of these genetic mutations, there's less steps to develop cancer. And that explains why we see earlier ages of cancer in families with genetic risk, because less things had to happen for them to develop cancer. So that makes sense. The second line I have there is multiple primaries. That's the term that we use to describe one person who might have got more than one cancer. And so somebody who got breast cancer and then got ovarian cancer 15 years later, somebody who had endometrial and colon cancer at the same time. And again, we can it makes sense when we look at this picture to look at it and say, oh, if every cell in your body, everything that you were inherited from your parents already had that first mutation, it's more likely that a cancer would develop in multiple places. The next line there is a very technical term for incomplete penetrance, is a term that we use in genetics to describe the fact that sometimes people have a genetic risk factor, something that they've inherited, but they don't actually get cancer. And that can happen as well, right? Because you could be born with that first genetic mutation, but not get all of those additional steps, or your body actually has a lot of mechanisms to try to kill off those cells that turn cancerous. So not everybody who's inherited a mutation will get cancer. And then, thanks, Monique, the last one is dominant inheritance, which is probably shown a bit better on this picture. So I have not said this yet, but most of the genes that are involved in cancer running through families are genes that we get 2 copies of. You get one from your mom and one from your dad. And this family tree is showing here a father who has 2 copies of a gene, the little box. And the white one, they're using the term affected, means that it has a genetic problem that causes cancer. And the blue box is the form of the gene that is working the way it usually does. And the mom here, we're saying, has 2 copies of the gene that are working the way we expect it to. When they have kids, you mix up your genes. You get to give half of your genes to each kid. And we can see here, whatever mom gives is always the blue box, but dad can either give the white box or the blue box. So this is the pattern of inheritance that shows us why, when this is going through a family, that some of the children are going to have the same risk as their parent, and some of them won't. And I want to just pause there for a moment, because I know that this is a very really, really difficult topic for a lot of people. If you have a family with inherited cancer risk, you have seen family members go through cancer diagnoses and treatment, you may have seen family members die from cancer. And a lot of times it's a really natural instinct to say, like, I just don't want to do the test. I already know bad things are going on in my family. I don't want to do a test just to hear the thing I already know. But I want to just pause here and say that even in these families with inherited risk, about half of the people do not get that genetic risk factor, and that can be really helpful news. So that's one thing I want to say. And even for the people who do have it, which is what I'll be talking about in a few moments, we can use that information. I know it's hard. I respect somebody's decision to postpone or take their time to get this information. But I have to remind myself all the time, we don't make something happen with a genetic test. Your genes are your genes. And if we can find out about something ahead of time and be on top of it, we have a real opportunity to catch cancers early and prevent them. So even though this is a very sciencey looking picture, I know there's a lot of human stories behind this. And I think I can move on to the next slide now, which is talking about genetic testing itself. So if you are having a germline or hereditary cancer genetic test, the genes that most people are familiar with are and this is a graph for ovarian cancer, showing that when we find families that have a genetic susceptibility to ovarian cancer, what are the genes that are involved? And we can see from this graph, it is most commonly BRCA1 and BRCA2, or BRCA1 and BRCA2. But there are many other genes that can be involved. And I picked ovarian cancer as the example because, as I mentioned earlier, this is a type of cancer where a higher proportion are genetic. And so it's really important for us to be paying attention to that. But if we picked another cancer, endometrial cancer, colon cancer, breast cancer, the important message is that there can be multiple genes involved. And so when you go to do a genetic test, it's really important that they are testing all of these genes, not just BRCA1 and 2, for example. And the next slide talks a little bit about how tests have changed over time. You do not need to read all of these boxes. Conceptually, what I just want you to tell you is over time, we started testing more things. If we think again, mostly in the world of ovarian cancer and breast cancer, we started off being able to test the BRCA genes 25, 30 years ago, but over time we've added more and more things. And I put this line around 2012, 2013 as a rough guideline, because one of the questions I get a lot for people is, oh, I had a genetic test in the past. Do I need to get retested? And I would say if you had a genetic test before 2012, 2013, and it was normal, yes, you should definitely be retested because so much has changed since then. If you had your test after 2013, there's literally like dozens of variations of germline genetic tests out there. So at that point, what I would say is, if you were tested after 2013, let's take a look at your test more closely to give you an individual answer of whether you need to be retested or not. Some people, it would be helpful. Other people, their test is actually still pretty up to date. And then one of the questions that Monique and I actually first met over discussing is for the families that have tested positive, even if it was in 2005, do they need to be retested? In many cases, no. Maybe we already understand what's going on in your family and we don't need to redo it, but we always look at individual families. Again, that would be more of an individual conversation. So again, there's lots of things on this slide, but what I want to say conceptually is tests have changed over time. So if you tested negative in the past, it may be important to repeat it. Thanks, Monique. Yeah, I can actually move to the next slide. I do want to mention here that there are different types of results that can come back on your test. So if you have had a genetic test, you've got one in a file folder at home or on a PDF, or you're going to get a test, how are you going to read that? The positive results are usually those first two lines. The technical term will be pathogenic or likely pathogenic. Sometimes it's called a positive result. That's something that tells us somebody's at higher risk for getting cancer. The bottom two lines actually don't get reported. Those are normal variants. But that third line, that middle section, variants of uncertain significance, this happens a lot. And I just really I feel like it's one of my biggest sort of messages I want to get out there is that most of these are normal. So if you have a genetic test report that says variant of uncertain significance or variant of unknown significance, we have to look more closely, right? Because if it says uncertain or unknown, we don't want to ignore it. We want to look at it. But I also want to be mostly reassuring and tell you that the vast majority of these are normal. Where do they come from? Human beings are not all the same. I'm not the same as Monique or Dr. Chen or anyone else when we look inside my genes, but most of those differences aren't problems. They're just normal variation. And that happens in cancer genes as well. There's normal variation. There's so much normal variation that we're still studying what all of it is. I think I've got one or two more slides. Yeah, so I want to kind of focus for the people, as I said, who, if you have a positive result already, or you get one when you do your genetic test, or your best friend has one, to remember the genetic test itself isn't telling somebody whether they have cancer or not. But it does tell us that somebody's at higher risk than the average person. And as I said, I know that's not what any of us wants to talk about, but if that's already there, if that's what you were born with, let's take that information and use it. Let's get extra screening, early detection. Let's think about preventive measures. I really also want to emphasize that genes vary. You remember that graph where like BRCA1 and 2 are such a big part of that pie chart. I still see sometimes where everybody, whatever people think is positive on their report, everybody thinks it's the same as BRCA. And it's not. There can be lots of variations in how high the risks are, what type of cancer they are involved. Some of these genes do involve a discussion of the option of preventive surgery. Some of them don't. It's extra monitoring. And so it's really important to know exactly what your result is, to know not all the genes are the same. You can look at it yourself or certainly work with your doctor or your genetic counselor to look at guidelines. I mentioned NCCN, the National Comprehensive Cancer Network, as a source that has a lot of good information on what all these different genes are and what their risks are. And I'm not going to talk too much about my last slide, but I just want to put it back up there to remind you. I think that about the variants of uncertain significance, that they come up often. In fact, we have research that says that depending on what type of test you do, up to half the people are going to get something that says uncertain, and most of these turn out to be normal. So I'm not going to go through every line on this slide, but I just want to say that we don't typically recommend surgery or screening or anything off of those. So I'm going to pass it on to Monique for her part of the talk.
Yes, thank you, Julie. And it is so important that we talk about these, genetic types of testing that patients can be getting. And even from my own perspective, I work in the field of genetics. I work with germline testing as well as tumor testing, but I'm also a triple negative breast cancer survivor of 23 years. And I had the testing done at the time of my diagnosis, and I do carry a BRCA1 mutation. And having that information has helped me to be able to make decisions on my care moving forward with my doctors, so that I'm still here 23 years later. I haven't had another cancer diagnosis. I was able to do some of those things that needed to be done to get myself to this place. So I want that for other people too. I want them to have that knowledge to make those good decisions. And with that, I'll just say we're going to kind of switch gears a little bit, because there's another type of testing that we've already heard a bit about today, and that is some somatic testing or tumor testing. There are lots of different names that we hear it called, and there are lots of reasons that we're doing this types of testing, but most of the reasons we're doing tumor testing is so that we can find better treatment approaches for patients that target them. It's a personalized way of treating those cancers. And so with that, I'll just say, every person's cancer has a unique pattern. It's really important that we identify some of the proteins and the DNA or RNA changes that are going on in these tumors, so that we can get this information about how aggressive is this cancer? Is there a likely response to a particular treatment? What's the prognosis overall for a patient that has the specific type of makeup of this cancer? And so this is really helping our providers to make the most informed decisions for treatment moving forward for care. And so there are some things that we think about when we're thinking about what we're looking for on tumor tests. And really what we're looking for are specific biomarkers. And these biomarkers can help us determine whether, someone might develop a cancer, but also, is this a cancer that's going to be aggressive? What's the prognostic? How is it going to look in the future for this patient? And so that's going to be really important because we think about, do we treat with chemotherapy? Do we not treat with chemotherapy? And another aspect that's really important is the predictive value that we see from some of these tests where we talk about, optimal drugs for this cancer. Do we know that there are specific drugs or treatments that this patient would respond to? And on the opposite end of that, are there drugs that maybe we shouldn't be thinking about for this patient because they're not going to get a good response to that? And so this is really important information as we determine those most personalized approaches for patients. And then another aspect that I find very interesting and just fascinating is this idea of pharmacodynamics. And it's really about doses, optimal doses for the patients, and which drugs are going to have the best effect, whether it's good effects or bad effects. And so we want to really be able to study that and to see that, to really bring the best outcomes for patients. And so I want to start, I just pulled a couple of different biomarkers here, and I wanted to kind of walk through them. I only, looked into endometrial and ovarian, so we'll do a quick view of that. But some of the things that have already been mentioned, like mismatch repair. So these are the genes that are associated with Lynch syndrome, but we can also see them outside of a germline or, in a hereditary sense, just in the tumor themselves. And these can be indicators for different uses with immunotherapies that we've heard a little bit about this morning. And then we've also got another gene, a POL-E gene, where if there are mutations in this specific gene in a patient with endometrial cancer, we know a little bit more about the prognosis. So mutations in this specific gene let us know that this patient may have a more favorable prognosis, and maybe they won't need to have chemotherapy. And so that's very helpful in the decision-making for treatment. TP53 is also one that's associated in hereditary cancer with a disease, it's called Li-Fraumeni syndrome. And this one we can also see in the tumor that's not in every cell of the body, but just in the tumor. We often see this TP53 mutation found there. It does seem to indicate that these could be more aggressive types of cancers, and they do have some guidance with targeted therapies as well. We heard a little bit about HER2 earlier on one of the presentations. Overexpression or amplification of this gene can cause proteins to be developed, right? This is also associated with a gene called ERBB2. So sometimes even outside of looking at that immunohistochemistry, we can also look at the gene alterations through the DNA and RNA analysis and think about potential targeted therapies that go along with what we might see in a HER2 positive patient that could be working for this patient as well. NTRK is another gene. If these are gene fusions that we see, they're very rare, but when we see them, we know that there are some specific drugs, TRK inhibitors, that could be very helpful for these patients. And then tumor mutational burden is another one. We see this one really associated with any of the solid types of tumors where there could be a predictive response to specific immunotherapies as well. And of course, like we've already talked about, there are clinical trials, there are research going on right now. There are lots of other biomarkers that we're looking at. And so these are going to be important for patients in the future. And so let's do the same with ovarian quickly. I think this will be my last slide, so we'll walk through it quickly, but you've already kind of gotten the idea here. What's unique about ovarian cancer is, as Julie talked about, BRCA1 and 2 are very common in the germline or the hereditary type of cancer, but also there is some potential for those to be indications for treatment with PARP inhibitors, which some of you may have, been on yourselves or heard of. And so even in just the tumor themselves, these can lend to an effective response for these patients. We look at homologous recombination deficiency. This is a deficient repair pathway that also includes those BRCA mutations. There are some other genes in that specific pathway as well. So when we see disruption or genomic instability in that pathway, these are also patients that could respond well to a PARP inhibitor. Again, the TP53 mutations, same type of scenario here, but with TP53 patients and ovarian cancer, we know that platinum-based agents may be something that they'll respond well to. PIK3CA is another gene. This helps us to look at those P13K inhibitors like alpelisib. Folate receptor alpha, this is something that one of the other talks mentioned earlier. It's going to be very helpful for those patients who have a platinum-resistant cancer, which many ovarian cancer treatments are going to be platinum at the beginning, and most patients over time will develop some type of a resistance to platinum agents. So this is another opportunity for those patients to find another targeted therapy that they can start. The FOXL2 is more of a prognostic type of indicator. MSI, which we've talked a little bit about on one of the other programs as well, is the microsatellite instability. And this can tell us some responsiveness to certain drugs, one being bevacizumab. Again, with the NTRK gene fusions, this is going to be important for those specific therapies with those inhibitors. And again, lots of emerging biomarkers in this field. So really, it's an exciting time for us to be involved in what's going on with cancer treatments, because there's so much to look forward to in the future with all of these new types of drugs that are being targeted for patients. So I think in summary, and I'll just summarize both of our talks, if that's okay, Julie. It's really important that we think about identifying these patients who are, at the most increased risk for cancer. And those really are those hereditary cancer patients. So patients who have one of those gene mutations, and sometimes even a patient that has more than one mutation. We need to be able to identify those patients so that we can hopefully identify cancers at an earlier stage. So early detection. In many cases, we can prevent cancers from happening. Great example is my own story with BRCA1 as a mutation carrier, having triple negative breast cancer, but doing the preventative therapies or the preventative surgeries and having my ovaries out, I've been able to avoid having another cancer like ovarian cancer that's very high with a BRCA1 carrier. And then obviously we've talked a lot about those targeted treatments, whether it's a germline mutation in BRCA1 and 2, or if it's tumor mutation, PARP inhibitors are, certainly drugs, options for drug treatment. Different genes have different risks, as Julie pointed out. So it's really important to know what gene mutations we are seeing in a specific patient so we can better stratify what those risks actually look like and what cancers they could be at risk for. And then tumor testing is really a complementary testing, right? So we're not doing that in lieu of germline testing. We're doing that complementary to it so that we can determine needs for specific treatments or de-escalating treatment altogether. And then also those ideal therapies, really taking a personalized approach for patients so that we can treat each patient uniquely, because that's what patients are. They're unique and they have their own story. And so we need to be able to be sensitive to that. So I think that is all for today in our talk. And I don't know if you had some final comments as well, Julie, so I'll lend that to you.
No, I think you summarized it perfectly. I didn't know, Dr. Chen, if you want us to answer some of the questions that are in the Q&A.
Yeah, thank you very much. I think that the distinction between germline and tumor testing is really important in this current environment where we've looked at all these different ways of targeting the tumor. We really do need to look at the tumor, but the germline is ultimately important for families and heredity and all the work that you do. There's a couple of questions that I think are worth answering before we move on. The first is, does the testing company notify the client if their test results change over time?
Yeah, I am so glad that this was asked. So the answer is yes, but not always. And you might, this is a good time to refer back to the slide where I said with our modern tests, about up to 50% of people have something called a variant of uncertain significance on their test, and most of those turn out to be normal. At some point, early, we used to kind of like every time something changed, we'd call you up, and it became very overwhelming. And Monique, I actually just heard that Myriad just changed their policy that if it goes away, like if a variant of uncertain significance, which your genetic counselor already told you, you probably don't need to worry about this. And now you really don't need to worry about it. We are no longer, that Myriad is no longer issuing a brand new report for that. And I would say that in clinical practice, that's kind of what's happening as well, based on just the volume. So I would say if it goes the other way, if something becomes pathogenic, or something was called pathogenic and becomes uncertain or benign, that's going to change what you're doing as opposed to the VUS change. And the labs make a lot more effort and we make a lot more effort clinically. But the bottom line is, we now have over 20 years of patient tests at all different labs. We have genetic counselors who've retired, who've moved to different organizations. So if you want to know what the most current interpretation is of your test, I always recommend that you ask directly to the lab or to your genetic counselor, to your doctor. You may hear updates. They can happen. We do our best. But if you want to make sure you're like completely up to date, I really recommend that you ask and check in. And the times to do that would be like, I'm having kids, my kids are having kids, I'm having surgery. I want, like, anytime that you think you're going to make a decision based on your test result, let's make sure it's up to date. So yes, you can hear things, but it's not a perfect system. Sometimes patients move. Sometimes we're like, oh, we're trying to find this person, but they've moved 3 times and we can't find them again. So it's always better to ask if it's important.
Yeah. And I'll just add on to that to say most labs are going to reach out to the provider who did your testing to let them know that a change was made. And if you're no longer in their care, then the labs will often reach out to the patient after that to find out who are you in the care of now and who can we transfer your records to. And then on top of that, I just want to add, every patient should have a paper copy of all of their results that they carry around with them. This is really important. And I think it gets missed in some cases sometimes. So that is your sort of documentation, and that your way to go back and look something up for yourself.
Yeah, I agree very much. And that's like one of our traditions in genetic counseling, is to be like, please take this piece of paper, please take this PDF. Also, because that, even though it might look like gobbledygook to you, that string of letters and numbers on that page means a lot to genetic counselors. And that's how we can tell if something is pathogenic or likely pathogenic or uncertain or benign or has changed. And so it's not enough to walk in and say, I have CHEK2 or I have RAD51C. We really need to see that string of letters and numbers to make sure we're giving you the right information.
Super. I don't know that we have time to address specific genes, but maybe just the concept. There's questions about P53 or about RAD51, about PIK3C. How should patients take these questions to you guys? I want to take it offline because I think we need to continue with our symposium. But if patients have questions about their reports and genes, what's the best way to approach getting their questions answered?
Talking to their oncologist, talking to a genetic counselor, and Monique, you can share what the labs have. But I want to say, I read those questions, and just sort of conceptually, the reason that the same genes show up in different places is all of these are genes that have a normal job, and the normal job is always a good one. It's either to keep your cells growing at a regular pace or repair damage that happens to your cells. So if you have a mutation in one of these genes, your cells don't know how to grow at a regular pace, or they can't repair themselves as well. And so that's why there's a lot of overlap. The same mutations can be germline or somatic. But I think that, as you said, there's so many individual variations. I would say talk to your oncologist, talk to your genetic counselor. And Monique, other things that you want to add to that?
Yeah, I'll just say, because I'm looking at some of these questions, and of course, the list that I gave you is not an exhaustive list. I wanted to just give you some examples of where immunotherapies and targeted treatments were going to be important. So hopefully that goes along with some of the questions that I see that are here in the chart. And so just keep that in mind. And then as far as like RAD51, there was a question about that being associated with disruption in the homologous recombination pathway. And yes, so there are several genes that are in that pathway. BRCA1 and 2 just happen to be the huge players of that pathway. So yes, there is an entire pathway full of genes, and some of those are also targetable.
Yeah, and I was just looking at the questions. I do also want to emphasize, because I know this symposium is sort of geared more towards people who have cancer. You do not need to have cancer to do a germline genetic test. We don't, somatic tests are not useful unless you have cancer, because those are all about treatment and prognosis. But the germline genetic test, we actually encourage healthy people to go and get it, or people who are had a cancer in the past but don't have it now. That's actually the perfect time to get genetic testing, is when you don't have cancer, because we can maybe catch it early next time or prevent it next time. So genetic testing is not only for cancer patients when we talk about the germline testing.
Super. Thank you so much for giving us an update and the highlights and how to navigate through all of the reports and numbers and letters. It's super important, and I think ties in well with our previous talks from this morning. As I announced earlier, we're moving the circulating tumor DNA talk to after our cancer genetics panel. I wanted to thank Julie and Monique for presenting this morning. And next, I wanted to introduce